Good afternoon and welcome to our third installment of our Human Resources for Health Spotlight series. And today's topic is, where do we find the money for smart health and care workforce investment? And this is the third installment. And as you know, we've been discussing previously other topic. And the crucial question here was, how do we actually fund the expansion of training? We know that there are still shortages. We don't produce enough doctors, nurses, and other health professionals. Where can we find the money for reform of training? We need to train for general practice. We need to train in remote and underserved areas. We need to train for teamwork. And how can we actually improve the working conditions? Where do we get the money for this? For the protection of health workers, for the physical protection, which was so much needed during COVID-19, but also, of course, for the mental protection. There are many health workers exposed to a lot of stress, burnout, but in many countries, we also need to address the question of the social protection, so sick pay and similar thing. And this all happens in a moment where we all know the fiscal context is becoming more and more tight. So what are the new resources? How can we mobilize money at domestic, international, regional levels? Where is it coming from actually? How can we ensure that there's more money coming for investment in health? And how do we target the investment? Nothing will be won if the money goes into the wrong pockets. We need to be sure that we do something good, that we create returns on investment in terms of course, better health outcomes, better access, better equity. But also, I think we need to change our narrative. We need to be much, much clearer now that investing in the health and care workforce is not only good for health and health system, but it's also good for other sectors. It's good for decent working conditions. It's good for pay equality. It's good for gender equality. And I think we need to spell out these co-benefits vis-a-vis the other sectors, especially when negotiating with finance, employment, and education. Now, these are all the topics we've actually discussed like 5 weeks ago in Geneva at the 5th Global Forum on Human Resources for Health, which was a great conference, and not just about technical stuff. It was really very much policy oriented for decision maker and follow-up action. And I'm so happy to have with us Barbara McPake. She is the first author of our policy brief on the resources, on the money, on the smart investment. She's actually from the University of Melbourne in Australia, and I was going to say something like, thank you so much for joining at this late hour, but she's at the moment based in Scotland, so it's quite okay, I think, for Barbara. As a spotlight speaker, we have today my colleague James Azamani from the WHO Regional Office for Africa. And we are most grateful to James because he has helped us with policy briefs, providing some insights in African countries and also helping us with a case study on Ghana. And he was briefing us with fascinating examples. And I think that we will learn a lot. We will learn a lot from other regions and other countries, even if they are low and middle income countries. And last but not least, for all of you following this series on the health and care workforce, I'm again very happy to welcome Jim Campbell, Director for Human Resources for Health from WHO Geneva. And Jim will act as a discussant and reflect a little bit, not only on what was said today, but also the other days, and provide us with a couple of insights and strategic options. Now, just a couple of things on the housekeeping. Please use the chat. We are collecting your comments, your questions, your concerns, and we will feed them at the end to our speakers. We will have a panel discussion. So to make sure that your questions are addressed, you will need to enter them in the chat. Second is we are recording this session, and we are doing this because swiftly after this webinar, we will put it on our YouTube channel just in case you want to see it again or you want to recommend it to somebody else. So that's it. And now, Erica, can I ask you to present the poll?
Just a quick question, just to see where we are as see where you are as an audience. First question is, has the government in your country increased investment in the health workforce? So that's a single choice question, yes or no. And then the second question is, what are the main factors shaping investment decisions about the health workforce? So is it acute health workforce shortages in specific parts of the system? Is it strengthening health system resilience? Is it about brain drain, losing health workers to other countries? Is it about insufficient training capacity? Or indeed, is it none of the above? So it'd be really interesting to hear where you are in your countries in these different areas. Thank you very much. Back to you, Matthias.
Thank you so much, Erica, and I'm quite curious to see the results of the poll. But without any further ado, I would like to give the floor to you, Barbara. Barbara, please.
Good afternoon, good evening, everybody. Pleasure to be here talking to you about this policy brief, which has been my pleasure to work with the other colleagues named here to produce. So first of all, I'm sure it comes as no surprise to anybody that pretty much everybody all over the world is complaining about healthcare workforce shortages, even though, of course, we know there are very different levels of healthcare availability around the world. And this was probably true before COVID, but is markedly so after COVID. And you can see a few examples from professional journals, academic journals, newspapers, and so on, all talking about shortages of workforce. Next slide, please. And probably, I think it's fair to say, the levels of shortages and the pretty universal experience of shortage implies that there's been chronic underfunding for years, and that this is the outcome of not just COVID itself, but of long failure to invest adequately in health workforce. And there's a whole series of reasons for that, some of which we'll talk about. But I think it's also important to recognize that the substantial efforts that are needed are not just to scale up investment. That's clearly important, but it almost goes hand in hand with scaling up investment, that we have to improve the efficiency of spending. Nobody will want to invest in something that is inefficiently spent. So those two things really need to be thought about together. The global strategy has projected that there would be 18 million a shortage of 18 million health workers by 2030. And although that's now been revised to 10 million, because there have been more investments in health workforce in a number of regions, the regions in which the numbers are lowest are the ones where that growth has not been happening. So the shortages are everywhere, but they are particularly in the regions that we all know have the worst situations: Sub-Saharan Africa, North Africa and the Middle East, South Asia. Now, that it also implies, I think, that countries are not supplying enough graduates for replacement. So this is why we have shortages everywhere in the world. But it can also be because although people are graduating, they're not staying in the health workforce after they've graduated, perhaps because there's not enough effective demand, which is not about need, but about whether people have the ability to pay for their health needs. Often that's done for them, and we'll talk about that a bit later. And that would mean that there then aren't sufficient jobs with adequate pay to keep people in the health system. And then with slowing economic growth in the aftermath of the COVID-19 crisis, there's clearly some very sharp issues about prioritization of investments in all countries, with health having to compete with other pretty urgent needs. So we need to make a really strong case for why health workforce needs to figure in that prioritization process and needs to come out strongly. Next slide, please. So I'm going to talk about the policy brief talks about three main key strategic investments. And the first one, it won't surprise you to know, is in education. And there are two elements to the education investments that we believe are particularly to be prioritized. The first is investing even before people may or may not choose to pursue a career in health. Need to think about the whole health worker life cycle approach, which begins when kids in school are thinking, what do they want to do when they grow up? And in later school are thinking about what college courses they're going to apply for and what their aspirations for their careers are. There are things we can do at that stage, for example, emphasizing STEM, science, technology, engineering, and maths in schools, and particularly stress including girls in those subjects, as we know they're historically underrepresented in those subjects. And also create opportunities for young people to engage in community public health before they make their career choices, so they understand what a career in the health system might look like. And then I think more predictably, there are major reforms needed in the health professional education systems from which health professionals graduate. Underinvestment needs to be reversed. We need to really emphasize interprofessional education. That means training different health professionals together and emphasizing competency-based learning, not book learning, but can you do the things that patients need you to do? It's not to say that books can't help you with the background to why you're doing it, but really focusing on producing what the ability to do the important things. We know there are big gaps in a lot of countries in the quality of education, and we can probably, to a greater extent, use online tools to support improving the quality of education. And we also really need to think about the diversity of the healthcare workforce so that it reflects the populations that it serves. So we need to think about how to better include underrepresented groups. Next slide, please. So the second key investment is about reskilling and optimizing the healthcare workforce. And a point that I think is seldom emphasized enough in health workforce conversations is that what we're trying to do is support the workforce requirements of primary care team-led health systems. In a health systems debate, it's very unusual for anybody to argue that we don't need a primary care-led health system. But when we get onto human resource debates, we tend to talk about how many nurses, how many doctors, irrespective of what we think their roles are in the system. And we really need to start starting with primary care teams. The figure on the right of this slide shows one idea of the configuration of a primary care team. It's radically different from an idea of a small clinic with a doctor and a nurse, which is maybe closer to the dark blue set of health professionals in the center. We need to think about the extended healthcare teams, so other disciplines that have often been neglected, like pharmacists, dentists, community health workers. But we also need to think about the extended community care team, which are shown in the light green, linking healthcare up with social support. Those things need to be thought about much more centrally when we're talking about healthcare workforce. Again, we need to exploit the opportunities to efficiently use digital health tools. And we need to think about distribution. We all know distribution is a problem nearly everywhere. There are proven interventions that work in multiple kinds of contexts, and yet we find they're not used. Just for one example, we know that if medical students and nursing students are sourced from rural areas, they're far more likely to be willing to work in rural areas later, and yet the number of initiatives that really emphasize recruiting students from rural areas are a microdot among all the recruitment of nursing and medical students that goes on. Next slide, please. Then the third area for strategic investment is in employment and incentive initiatives. So several things need to be done here. First of all, stimulating demand in the labour market. I mentioned earlier that ineffective demand is an important reason for shortage. That means, to a great extent, extending fiscal capacity to increase employment of health workers in the public sector. Public sector is going to remain or sustain as the main sector that employs nurses and doctors and other health professionals in most, if not, and certainly many countries, and therefore supporting effective demand means supporting fiscal capacity. We need to address migration, the problem of international migration and the poaching of health staff from countries that can least afford them. really got a lot of attention in the early 2000s, and then for a whole host of reasons, the rates of migration plateaued. But they started to climb again even before the COVID-19 pandemic, and they are becoming major issues again for many countries. In order to look at migration, countries which tend to send health workers to other countries need to look at the push factors that make people want to leave, and the countries that receive them need to make sure that they're adopting fair, transparent recruitment practices. And I don't have much time to say very much about this, but I think it's really important to look at the issues of the public-private mix and how we achieve the health workforce that is supporting the delivery of the public good, not just the interests of those who can pay the most for healthcare. And that means a very careful management of the public-private mix. Thank you. Next slide. Then carrying on under strategic investment 3, we need to support and protect health workers from the issues that we know are really enormous in the health system: burnout, overwork, and a feeling of being undervalued. And in fact, in many countries, declining relative pay rates. That means referring to the ILO's decent work agenda as many useful points to think about in terms of making sure that employment practices support retention of health workers. And also in healthcare in particular, it's important to think about safe working environments that enable health workers to deliver services effectively. And there's a shocking gender pay gap in the health system, which is in many health systems even larger than the pay gaps in other systems, which is particularly shocking given the female domination of a lot of countries' health sectors. And then finally, we need to think about managing performance. And here's where the third stage of education comes in: continuing professional development, which is often a neglected area, tends to be a bit ad hoc. When somebody brings a new training program in, something happens. When they don't, there's nothing systematic going on. It means thinking about how to use internal and external peer review, recertification, external assessment. And then we also need to think about providing incentives and resources for improving performance, which again can mean things like management strategies, information provision, and again, peer review and using peer group influence, even if it's normally interpreted to mean individual level financial and non-financial incentives, which actually the evidence is quite unsupportive of, largely speaking. But again, these things tend to be context specific, so one shouldn't generalize. Next slide, please. So the rest of the policy brief turns to the question of how we can ensure sufficient funding. Once we've figured out what it is we need to invest in and how to spend that money well, what do we need to do? I've already mentioned the importance of protecting and increasing public revenues and fiscal space for health and health workforce. And arguments about spending efficiently are much more effective arguments than arguing about the need for spending. If you can't say you can spend it efficiently and effectively, it doesn't matter how big the need is. Clearly that needs political leadership, intersectoral collaboration, obviously with the education sector, where a lot of resources related to human resources for health sits, but not only education. We need to think, for example, about civil service administrations and other social sectors where as we've already said, we need to join up health and social care much more effectively in many countries. We need human resources for health units in ministries of health, and many countries now have these, so that they're doing the analytic work to support effective and efficient spending. We need to improve governance of private investment and governance of public-private partnerships, of which there are a number of scandals and problems around the world where that hasn't worked well. And we need to improve budget efficiency in the health sector more generally. Next slide, please. And there's some opportunities in this post-COVID world to rethink external sources of funding. Fiscal space in many, if not most, low and middle income countries is not going to be sufficient for some time to support the scale up of health workforce that's needed. So we're going to require cooperation at multilateral, regional and domestic levels to invest. There are good initiatives around, like in the EU, in the Inter-American Development Bank. There has been growth in investment in health workforce through development assistance. But having said that, it's not always targeted well. Some of these ad hoc training programs that I mentioned earlier absorb a huge amount of all that, and they're often not terribly strategic and often rather short-term and not system-focused, but specific problem-focused investments. And there may be a new pandemic preparedness financing mechanism in the future that might provide opportunities for new sources of funding. Next slide, please. So just to conclude then, here are the recommendations, which I think also wrap up everything that I've been saying. First of all, recommendation number 1, oversupply of health and care workers is the only solution to current challenges. And by oversupply, we mean thinking more about than about the immediate needs for service delivery in a stable state, with all sorts of issues about needing to plan for attrition, needing to plan for growth, needing to plan for potential new pandemics. So not just thinking about trying to get the right numbers, but trying to make sure that the supply exceeds what those numbers seem to be, because we need to anticipate future demands and future growth. We need to invest in education that creates human capital and expands access. I think I've said plenty of that, so I don't need to say more, but it's recommendation number 2. And then recommendation number 3 is actually a cautionary note. The investment will be wasted if we don't support and protect the healthcare workforce. We'll put loads of effort into training and producing graduates who will not stay in the sector. And that's an enormous waste of money and will not make a convincing case to funders. So thank you very much. I look forward to your reflections on those points.
Thank you so much. There was a concise and excellent overview on the policy brief and the work you've done with your team on it, and we are most grateful. And it comes to me almost like a menu you could pick on for smart investment: education, primary health care, employment, and incentives. And you also raised the issue about the external resources, which is not really fully in order at the moment and which needs to improve quite substantially. So that's really great. Thank you so much. And that's the moment where I would like to ask you, Erica, to present the results of the poll.
Yes, thank you very much. Really pleasingly, sort of nearly 1 in 5 of the people who responded to the poll said that it's the acute health workforce shortages that are the thing that's driving forward investments, but that 3/4 of respondents say that yes, there is more investment in the health workforce in their countries. So perhaps, well, maybe not 3/4, 71%, but yes, some interesting things coming through. Matthias.
Thank you so much. And I was already, well, not surprised, but actually kind of interesting that quite a lot of participants have apparently observed some investment in the health workforce, which is not such a surprise because we heard about COVID-19 and that countries have put more money into the health workforce. But unfortunately, we also hear reports that this is now going to recede and that the money may not flow in the long term. Thank you so much, Erica. And now it's time for me to ask James to come on board. James, we're very curious to hear from you, and thank you for joining from Brazzaville, James.
So I would like to share some perspectives from the African region regarding how do we stimulate the investments into the health workforce. We would all agree that investment in health workforce globally has not been up to what is expected. There is a gross underinvestment. And irrespective of whether it's from a low or middle income country or high income country, there is some room for improvement. Although the magnitude of the underinvestment is different and maybe more pronounced in low and middle income countries. But there are still lessons to learn irrespective of which countries that where the lessons are coming from. For example, in this slide, it summarizes the problem of the African region, where we're doing so much in terms of adding workers, adding 1 million workers in 8 years between 2013 and 2020. But that is far less than the rate of growth in the, that is required to meet population health need. And we are still grappling with about 5.3 million shortfall of health workers, as estimated by WHO in 2022. And if we want to make progress towards universal coverage, look at this graph, what is required to even meet the median attainment of the tracer indicators in the global strategy. More than 90% of the countries are nowhere near it yet. So this is one problem, huge shortfalls. And I believe these shortfalls are not limited to Africa. But on the other hand, even those that we do have, we're producing at least 150,000 health workers per year, data from 39 countries. And of this number, we are unable to absorb 1 in 3. And for nurses and midwives, it's even worse, we are unable to absorb up to 41%. To do this, it requires 43% budget increase in the workforce spending. With COVID-19, more conflicts, political instability, and the debt crisis, this situation has actually gotten worse. Data is still emerging, but it is showing even a more difficult situation. The other angle is migration of health workforce, which has recently increased, is a living reality in the African region. And an example of one story from a Nigerian hospital, where they said 15 health workers resign every week to migrate. If you go to my home country, Ghana, there are 16,000 applications at the Ministry of Health of nurses intending to leave in 2023. If you go to Zimbabwe and Kenya, we have roughly 41% of health workers planning to leave. All of this is because not enough investment is going into what will retain them. But if we look at countries in Africa, the investment in health more generally is below what is expected to be able to deliver minimum services. But even that, let's look at how much of that investment that is going to health is being prioritized for workforce. So we use a global median, globally, the median investment in workforce as a proportion of health investment is 57%. In the African region, we do have countries that do much more than that, but that's because the overall health spending is also so low, so almost everything is going to the health workforce. But we do have so many countries doing far less than that, and the African region median is 45%. That means even if we were to go by the global median, we should be doing at least 12 percentage point more on average. So in these countries, different sources of getting more funding has to be explored. For those doing far more, maybe 50, 60, 70% of their health spending on workforce, you can't ask them to do more than that. You can only ask them to find more money for health within which workforce can get. And for countries that are doing much less than the regional median and the global median, you can argue that they can better prioritize the workforce. And so understanding this is very important. And it is based on this that the African region is working towards having a common workforce investment charter that lays out principles that we can all agree that following this principle will lead to stimulating more investment in the health workforce. And I would like to briefly, this is actually my last slide, I would like to briefly touch on a few of these principles. One of it is about government leadership and stewardship being the cardinal point for ensuring that workforce investment is coordinated. And we don't go, you remember Barbara's point about much of the investment is going to train the same health workers on the same things and not adding extra hands to the workforce. And training the same health worker over and over again does not improve coverage. It can only divert services from one service to another, but it does not improve overall coverage and outcomes. So government leadership and ensuring that the workforce needs are well planned, costed, and government is leading in it to have this being very coherent. And in so doing, the prioritization should be based, that's our principle number 2 for the charter. Prioritization should be based on evidence that is generated locally, taking into account the labor market dynamics and the population health needs. And number 3, ensuring that there's alignment and synergy between government, private sector, and investment partners, international partners, so that they all work from the same plan working towards the same goal. This it's recommended they aspire to have an investment plan that is signed as a compact to guide their actions. This is how we may avoid duplicating investing on the same thing from different partners. That leads to just one result instead of getting us bigger results. The other one is, how do we stimulate new investments? This is where we focus on. For example, international financial institutions should begin to classify any investment into workforce, whether in the development, in the employment and retention. All of that should be classified as human capital investment, and government should be justified to take loans to invest in that. And any investment that government is going to make in any health infrastructure taken from an international financial institution or any other partner investing in any infrastructure should have an explicit line on how much of this is going to strengthen the workforce in education, in employment, in retention, and in their performance. And finally, looking at sustainability. Sustainability from the start. Every project, every initiative, right from the start, need to build on existing mechanisms and strengthen the workforce, avoiding as far as possible silo approaches, focusing on one cadre, and ensuring that from the start there is a transition plan to ensure sustainability. Focusing on the long-term big picture rather than the short-term quick fixes that yield only outcomes that satisfy project needs, but not the needs of the health system. And in so doing, investing more in primary healthcare, whatever resources that come to invest in health workforce, we should be able to demonstrate how much of that is going to primary healthcare, how much of that is actually being spent to ensure that workers are protected and that our investment do not go waste eventually. So these 5 principles, we do believe, are not only useful for the African region, but in any context, when they are applied in a contextual manner, we would be able to stimulate new investments, align our priorities, and be able to sustain, first protect the workforce budgets at the moment, and sustain future investments that can lead to at least reducing by half the current shortages of health workers we have by 2030. I will stop here and more than happy to share country-specific examples, how some of these principles have been applied in the African region. Over to you, Wisdom.
James, thank you so much for this excellent overview on the WHO African region and for all the work you've done. And I understand from your presentation that despite investment in the past and the growth of the health workforce in the region, still far off the targets of the different targets actually. And even if they produce more, it's not always a given that the employment will follow. I saw this gap between, graduates and employment opportunities, and Barbara was actually referring to it in the previous webinars. We were also talking about that employment is very key to absorb the health workforce. Migration plays another important, but not only migration, but also loss of health workers to other sectors. And the figures you showed leaving after COVID-19, they are quite dramatic actually. And also, I mean, and this makes this policy brief and the discussion we have today here, and also the Fifth Global Forum so relevant. The investment is still far too low in most of countries in the WHO African region. And thank you also so much for turning to the Health Workforce Investment Center. I'd be very curious to learn more about it. Maybe there's the opportunity in the chat. Thank you so much. But now it's time to turn to Jim Campbell, Director for Human Resources for Health in WHO headquarters, Geneva. And Jim, you heard all the speakers and you remember very well the speakers from the last 2 installments of the webinar and of course the Global Forum. Please fill us in with your insights and foresight also. So what's coming next actually? Floor is all yours.
Thank you very much, Matthias. Good afternoon, good evening, colleagues. Good morning, wherever you're joining from. I can see in the chat people from around the world. Thank you very much to the European Observatory, to Barbara and James for their remarks. 4 points, Matthias, just as I was listening to this conversation. You mentioned that in your opening remarks, the 5th Global Forum, which we held 5 weeks ago now. under the theme Protect, Invest Together. The paper that Barbara has presented, the highlights, the summary, one of 3 policy briefs looking at some of the critical issues that the forum was discussing. And alongside that, we also had 3 civil society action briefs, which said, okay, based on this evidence, what actions can we take to drive it further forward? That forum had on the day 3 really 2 major discussions around an investment roundtable and a financing roundtable, talking about many of these issues, and all of that is available on the European Observatory website and on the Global Forum website. The messages that we've heard today really driving some of that consensus, and that's the key consensus, the point 2 that we're talking. We've very clearly in the evidence paper, the civil society brief, the dialogue that we had with member states and partners, that investment really does need to hit some of these key things. Firstly, that we need to invest in, protect our investments against any economic downturn that we're seeing around the world. We need to invest in today's workforce. As Barbara talked about, the gender pay gap, the occupational health and safety, decent work, fair pay has to be at the center to offset what James was talking about some of the attrition and retention challenges and the migration challenges that come forward. We need to ensure that investment education, and thank you, Barbara, for emphasizing, the solution is very clear. The evidence tells us we need to look at oversupply, a human capital investment into the socioeconomic and the co-benefits. That oversupply and that education needs to be improved, though. It can't just be continuing to generate the same or more of the same, but we have to drive investments into universal health coverage, health security. And let's be a bit more accurate about that. Primary healthcare and public health, and to ensure that we have that capacity in our neighborhoods for family medicine, yes, but also for dentistry, for oral health, for ophthalmology, to make sure that we've got integrated care services with mental health alongside it. So really driving that neighborhood investment for primary healthcare and public health to reach those global ambitions. The third point I wanted to make, Matthias, is that this is a debate which is not just unique to one element of health and care. It's about integrated health and care services and the investment necessary for that. And it does then, as you saw from James's presentation, when you look at the country level, you look at those shortages, where is the budget? Where is the investment needed? And let me quote Professor Duncan Selby of that, who's the president of the International Association of National Public Health Institutions around the world. And he's said on a couple of occasions recently, you know, through all his many years of experience working in health and public health, is don't tell me what you care about. Don't show me your strategy. Show me your budget. And through that, I will be able to tell what you really care about. And so we really need to emphasize this trajectory taking forward. What we do next is around action. And that's the fourth point. What action can we take? Barbara's evidence, the European Observatory brief, the consensus that we've seen, we need to take action. Today in the UN General Assembly is the multi-sectoral stakeholder meetings, preparing for the high-level meetings on universal health coverage, tuberculosis, pandemic preparedness. We're at the halfway point of the SDGs. 3 years lived experience through COVID-19. What actions will we take to have those investments necessary? We will be convening here in in Geneva, the World Health Assembly in just over 10 days' time to have these discussions. And one of the events will continue this theme. What is the action-oriented agenda? Where's the investment? Where's this working together to not just describe the problem, but invest in the solutions? Matthias, back to you.
Thanks a lot for these very sharp messages. And I will use this "show me your budget" line. I think that's really excellent, but it's true. And I can only hope that WHO at headquarters, but also in the regions, is budgeting the work on the health and care workforce adequately, because what you guys in headquarters do, and also the work I learned from Armani, is so helpful and so important, and it needs to be further advanced. That's absolutely clear. We come now to our panel discussion, and I would like to ask all panelists, all speakers, to switch on their camera. And Erica, I saw there were quite a number of messages coming through the chat box. Can you fill us in a little bit and feed them back to the panelists?
Yes, some really interesting stuff coming through the chat box, and some really quite difficult questions for you to answer, which is a good thing. So one of them is about how can we go beyond these sort of non-binding ethical codes for international recruitment to support health workers and health worker development in low middle income countries. Should we actually be talking about funding for training in the lower income regions of the globe? Also, what works best in high income countries? Is it about the financial or the non-financial incentives? Indeed, is it actually the same, whether it's a high-income country, a middle-income country, or a low-income country? The incentive, the financial and the non-financial incentives, pretty much the same across the board. Is there a role for the private sector in financing health workforce development, given that one of the imbalances we have is between the public sector and the private sector? And you mentioned dual practice. So are there any examples of good practice in managing dual practice? And I think that's enough to be going on with.
Yes, thanks a lot. Please, Barbara, pick the question out you feel best suited to respond to, and we make sure that all the questions will be addressed either by you or by others. Please go ahead.
Right, thanks. Well, I think I'll pick the private sector and the dual practice question, even though I think all those questions are interesting, and I'm itching to respond to all of them. But let me just focus on that one and let others deal with the others, especially as I've done quite a bit of work on dual practice myself, and I think it's there's a real dearth of evidence and good policy development and so on around. Which is not to say that there's nothing or that there aren't some interesting opportunities. I think one thing that we've proposed in some of the work that we've done is that we think about dual practice not only as when somebody has a public sector job and they also have a private sector job somewhere else. That's obviously dual practice and needs to be considered. But there are a lot of other ways in which health workers juggle dual public and private roles. For example, in a lot of countries, they have private wards and private clinics within public facilities that offer health workers private returns for doing some extra work, or at least it's always framed as extra work. I think it often actually does substitute from the core work of serving the public sector areas of those countries. And also the whole set of questions around informal payments, which are prevalent in a number of settings, are also about health workers combining public and private roles, but in a way we've called integrated, when you're doing a bit of public and a bit of private at the same time. And if you think about those three kinds of ways of doing dual practice, you can see some other opportunities for trying to manage dual practice rather than just telling people what they are and aren't allowed to do. So, for example, I think a promising strategy for managing dual practice, especially in countries where the regulatory frameworks are unlikely to be strong enough to simply ban it or to restrict it to a certain number of hours or to certain times of day or any of those kinds of things that are common practice, common regulatory proposals, but are poorly evidence supported. I think those private wards in public hospitals can be a mechanism to help offer people more regulated opportunities to do private sector work within the public domain, rather than having them go off and do things not what, where not, or how outside the public domain. There are lots of issues there. We've done a lot of work showing that those public wards and clinics aren't necessarily healthy for the quality of care for the people using the rest of the hospital. There's a lot of other things need to be done, but just as one set of ideas, we think about all these ways in which health workers combine public and private roles together and use the various leverage points that public actors have in there to try to frame a dual practice strategy, rather than just try to control what can be pretty uncontrollable health professionals with a regulatory stick. I mean, if you're in a hospital where there's a huge shortage of senior doctors, and you're trying to tell a senior doctor that there's some kind of penalty for going off and doing private practice on the side, you're in a very weak position. And the chance that the doctor will just say, well, if you're not going to let me do that, I'm just going to go somewhere else, and therefore take all your authority away from you, is large. So think about a broader framing of what that issue is.
Thank you so much, Barbara. I think that was a very thoughtful and very rich response, and it reminds me very much to some European countries. Actually, I remember, for example, Ireland's Lancashire, they are trying to reduce private practice in public health hospitals for equity reasons. And it's very difficult, because if you are too harsh, if you regulate too tough, then you drive out some of these consultants and doctors into private facilities. And that is something you don't want to do, because then you have an ethic issue on an even bigger scale, actually. So thank you so much for this. James, please, which question are you going to pick out?
Thank you. I think I will take what works in countries, financial or non-financial incentives. And what I would like to say is that financial and non-financial incentives, as we've seen it in practice, there's what we've seen in literature and there's what we've seen in practice, is that none of them works in isolation. So it's not an either or, they are complementary, and they have to be pursued alongside each other to give maximum impact. But one thing that is for sure is that non-financial incentives are ineffective without financial incentives. And now we'll provide one quick example. In 2021, Zimbabwe lost 5,000 health workers. The government, through evidence that they generated and figured out what to do as a stopgap measure, introduced a wide range of interventions to address this surge in migration. The bulk of that was financial incentives and some non-financial incentives and some regulatory mechanisms. By the end of 2022, the number of people who left the system reduced by 43%. And that 43% reduction led to them retaining 1,300 health workers, principally nurses, doctors, and laboratory workers who were otherwise at the verge of leaving. When we tried to dig into the data, we found out that the financial incentives, which in my view costed less than the non-financial incentives, made the most impact. Now, this is not to weigh it towards financial incentives more, but what I'm trying to say is that in some contexts, very low remuneration, then financial incentives plays a bigger role. In some contexts, remuneration are quite considerable and maybe a little somehow acceptable by workers, then non-financial incentives could have a bigger weight. The context varies, and each context should be taken, each situation should be taken on a case-by-case basis, look at the context, and through analysis, understand which of them need to be given higher weight, but both has to be explored complementarily, not either or kind of intervention. I think this is what I would say about financial and non-financial incentives.
James, thank you so much. That's really very helpful, because number one is that you stress that you need to balance both of them, and you also need to fully understand the context. And I guess that in Africa, the context will differ from country to country, and how you combine them, what are exactly the incentives, will be the same like in Europe, where we, for example, discuss medical deserts. How do we get general practitioners and specialists into remote and rural areas? And sometimes we give them financial incentives, but only those go and take the financial incentive that would have gone anyway. So it's really, but also interesting, you said, if I understood correctly, the financial incentives in the end, they are not so expensive if you look at it at the global thing, and at the loss, at the loss of all the people there. So thank you so much. So more evidence on instruments that work and how they can be made work is very, very much welcome. Jim, please, which question are you taking?
What do we do beyond non-binding ethical codes? What can we do around education and training to come through? So just a couple of things. We've had these discussions. What should we need to do? And actually, member states have adopted 2 resolutions in the last 2 years, 3 resolutions in the last 2 years, which set out the actions that need to be done on protecting, investing, and safeguarding the workforce, on strengthening the delivery for nursing and midwifery, and adopting the Working for Health Action Plan, and a whole series of recommendations in those. The Bucharest call to action, the Declaration on Human Resources for Health that was convened by Minister Refila in Romania, over 50 member states participating, a clear set of actions. And Barbara's here, she's facilitating support for a process, a regional action plan in the Western Pacific region, which again sets out the action. So it's what we need to do is not continue to diagnose the problem, but actually come with those actions that member states partners have already endorsed. And one of that must be to invest in education and jobs, to look at getting to this 8 to 12% production capacity. We know that can have an impact on high-income countries immediately to be able to deliver integrated health and care services against population needs, and will reduce their dependency on migration and international recruitment. That same level of investment could double the workforce in the 55 countries around the world that are on the Health Workforce Support and Safeguards list, with low density, low coverage, doubling the workforce in less than a decade, aiming for the SDG targets, and would cost less than 0.5% of GDP, which is a fraction of the investment that we've seen during COVID-19. So the actions are there, the diagnosis is there. It is about working together to take that forward. So that's let's actually walk the talk and do what we say we do.
Well, thank you so much, Jim. I think that's a very clear message from your side. It's not so much about, the evidence anymore, because we have a lot. Of course, any evidence can always be better, but it's really about the implementation. I think also about the political strategies, to get this done. And I think the way you have shaped the Global Forum was exactly pointing at this, that we need to have not only the technical consensus on what can be done and needs to be done, but also that we move on and expand this consensus to the political sphere. We have just 2 or 3 minutes left. Maybe very quickly, James, if you want to pick up another question, and then Barbara, I would like you to close the session with me with a couple of comments. Yeah, James, any other question you would like to respond to?
Yeah, one of the questions I want to respond to is, what is the number one thing that should be done by ministries of health to convince their governments that investing in the workforce is a worthwhile investment? So there's a thing, I believe, and I've been in the space for workforce planning for not so long, but quite some time now. And one of the things I've come to realize, and this is from my practical experience, is that ministries of finance are very, very prudent when they want to allocate resources. And they are prudent, because of their prudence, they will allocate resources to where they understand the most, where they are convinced putting the money here would yield what we want to get for this country. So in health, we are very good technically, generating our evidence and making nice policies and strategies, but those ones do not speak to what the Ministry of Finance are looking forward to do. It's about time for us to convert our technical evidence. We speak about health, and let us speak about money. And let us tell the Ministry of Finance how much we are adding to the GDP, how much we are protecting the economy. And if that was not there, what would be the loss, the cost in the loss that they would get, and let's speak their language. In so doing, let's generate the evidence with the Ministry of Finance. I've been in some countries where after we have done work, the Ministry of Finance colleagues are those calling us to say, we want that report because they were part of it. They provided the data, they did the analysis partially with us, and at the end of the day, they own it, and then they want to use it to take action. I think these steps would lead to action by Ministry of Finance. They are not too difficult as we thought they are. They want us to speak their language.
Yeah. James, thank you so much. And I'm very happy that you're saying this because to some extent, it echoes very much how I've seen the Global Forum. You know, we've been talking about, first of all, we got the evidence, but we need to have our own political strategy, our own data, our own planning in place for the homework. And if we have done this, actually, we can talk to these people and need to talk not just in terms of expenditure, but in terms of investment, co-benefits, what are we contributing to employment, to the wealth of the nation, to all good things in this world. James, thank you so much for this contribution. And Barbara, we've got 2 minutes, please. What are your key messages coming from the webinar now?
Okay, well, the first one I want to make is not really coming out of the webinar, and I think has been a hole in what we've discussed in the webinar. So I want to pick up on it. And this is the point that human resource strategies and policies don't stand alone. They have to relate to what the health system is trying to do. And I've never heard a coherent argument against the notion that what we're trying to do is move towards primary care-led health systems. And we really haven't heard much about the difficulties of transitioning from a human resource mindset that's counting doctors and nurses to one that's thinking about the breadth of skills and competencies that we need for a primary care-led system. So the first point I want to make is that's really important. It's really difficult and it needs a lot of thought. Obviously, countries are in different places in relation to it, which is perhaps why it doesn't come out so clearly from a global webinar. But I think in a lot of countries, that's your number one issue, that you're planning a human resource contingent for a health system of the past. So my second point is really to reiterate 2 things that have been said. Spending money is easy, spending money well is hard. And this is where I take slight issue. Obviously, it's a good point. Tell me your priorities, show me your budget. But there's no point in caring about something and then throwing money at it in an ineffective and inefficient way. And therefore, unless there are good, convincing opportunities to spend money effectively, we will find that budgets aren't allocated, however much a government cares. So it's really important to think about how to make sure that investments are not only efficient and effective, but can clearly be seen to be, and using evidence and monitoring impacts and so on. I think too few countries are really doing that.
Barbara, thank you so much. You're building
not like my
fantastic.
third point. That's all right.
You're building a fantastic bridge for me, and I walk over it now because on Thursday at lunchtime we have a webinar on skill mix innovations for primary and chronic care, and this is exactly what you're saying. You know, it's not just the numbers. You know, not just making it bigger, but really target how can we support with investment in the health and care workforce, primary care models of care. Thank you so much. Thank you so much to the speakers. Thank you so much, Erica and Lucy, for organizing in the background the technology. And I hope to see you all again on Thursday at lunchtime. Bye. Take care.